Welcome back to the Masterclass, students. I'm Harshal, and today we're unpacking the absolute high-stakes intersection of Medicare quality programs and inpatient DRG coding. If you've been following along, you know by now that assigning a code isn't just about jotting down a diagnosis, it's literally about defining the exact quality of care a hospital delivers. Today, we're bridging the gap between your clinical documentation, precise coding, and the massive financial penalties tied to patient outcomes.
But real quick, before we dive into the heavy stuff, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. It really helps keep this entire 150-part IPDRG masterclass free and accessible for everyone. All right, let's take a quick peek at today's roadmap. We'll do a fast recap, jump into the big CMS quality programs, break down those high-yield metrics you need to know, talk about CDI precision, and then wrap it all up with a teaser for next time.
Let's kick things off by building right on top of what we covered last time. We want to make sure that foundation is rock solid before we add this new layer of complexity.
So, in Part 135, we went deep into defending against clinical validation denials for tricky conditions like sepsis, encephalopathy, and malnutrition. And we established a golden rule, right? Your clinical indicators, things like elevated ammonia levels for encephalopathy or high lactates for sepsis, absolutely must perfectly justify the codes you're billing. If the clinical picture doesn't match the code, payers are going to downgrade that DRG in a heartbeat. Today, we're taking that exact same logic and applying it to how the government grades a hospital's safety record.
Moving right along to the CMS quality programs. What's really fascinating here is how CMS, the Centers for Medicare and Medicare Services, is fundamentally rewriting the rules on how hospitals get paid.
Think about the old days of healthcare for a second. We used to be in a volume-based world, where hospitals were paid just for the sheer quantity of care they cranked out. Fee-for-service, right? Well, those days are gone. Instead, under the Inpatient Prospective Payment System, CMS now links your MSDRG reimbursement directly to value. That means clinical quality, patient safety metrics, and overall patient experience are what actually dictate the final payment. It's a total game changer.
And here's why this is absolutely crucial. Failing to document accurately can trigger massive financial penalties across three core programs. First, you've got the Hospital-Acquired Condition Reduction Program, or HACRP. This slaps a mandatory 1% penalty on total Medicare reimbursement for bottom-performing hospitals. Next is the Hospital Readmissions Reduction Program, HRRP, which can dock up to 3% across all Medicare discharges if you have excess 30-day readmissions. Finally, the Value-Based Purchasing Program redistributes a pool of funds based on safety and efficiency. We are talking millions of dollars on the line here, folks, and it's all driven by the codes you assign.
So, how do you protect your hospital's revenue and reputation? You absolutely must master the POA indicator. Present on admission is the legal threshold. It is literally the dividing line that separates a pre-existing illness from a penalized hospital-acquired error. Officially, it means the condition was present at the exact time the order for inpatient admission occurred.
To do this, you've got four main flags to work with. Y means yes, it was present, meaning it can validly increase your DRG weight as a complication or major complication. N means no, it wasn't present, meaning it's a hospital-acquired condition. U means you have insufficient documentation, so you've got to query the doctor. And W means the provider is clinically unable to determine it. Listen closely to this. A single N flag can cost your facility thousands of dollars if a major complication is deemed a hospital error simply because CMS will flat-out refuse to increase the DRG payment for that condition.
Let's get into the high-yield quality metrics and see how these penalties actually manifest on a patient's chart. There are specific high-risk hospital-acquired conditions, HACs, that are non-reimbursed secondary diagnoses. If a patient comes in and subsequently develops a stage 3 or 4 pressure ulcer, or say a catheter-associated urinary tract infection, or worst-case scenario, there's a retained foreign object after surgery, CMS is not going to pay the higher DRG rate to treat those errors. The same goes for in-hospital falls that cause fractures, or manifestations of poor glycemic control like diabetic ketoacidosis that develop during the stay.
And building on that, we have composite metrics like the AHRQ PSI-90 safety indicators and the 30-day HRRP measures. These look specifically at things like iatrogenic pneumothorax, postoperative respiratory failure, postoperative sepsis, and readmissions for heart failure, acute MI, or elective joint replacements. If your coding doesn't accurately capture pre-existing complexities, your hospital looks like it is causing these complications, which artificially inflates your penalty risk. You definitely don't want that.
Let's put this into perspective with a real-world scenario.
Imagine a patient where the principal diagnosis is sepsis and they also have type 2 diabetes with ketoacidosis. Both were present on admission. But a few days in, the patient develops an acute deep vein thrombosis, a DVT. Because it developed after admission, it gets flagged with an N for POA. Now, normally, a DVT is a major complication or comorbidity, an MCC. But because it's an AJOC in this case, policy dictates it cannot be used to increase the DRG payment. The hospital gets paid for the base sepsis DRG, but completely eats the cost of treating the DVT.
So, with the financial and reputational stakes being this incredibly high, you might be wondering, at what exact moment should a clinical documentation integrity specialist, or CDI, step in and query the doctor?
Well, that brings us straight to our next topic, CDI precision, and how we harmonize quality with DRG logic operationally.
You essentially have two main lines of defense here. First is the concurrent query. This is raised while the patient is still actively in the hospital bed. It's an absolute best practice to review the chart within the first 24 to 48 hours to lock in that exact POA status while the clinical picture is fresh in everyone's mind. Your second line of defense is the retrospective query. This one is raised after the patient is discharged, but crucially before the claim is finalized and billed out.
I want you to basically memorize this mantra right here. Clinical accuracy equals coding accuracy equals financial accuracy. It perfectly explains why your role in clarifying ambiguous documentation is the heartbeat of the hospital's revenue cycle. It protects against undercoding, which drains the hospital's case mix index, and it vehemently defends against upcoding, which is a massive fraud risk.
But look, you can't just go up to a doctor and tell them to change a code so the hospital gets paid more. When building a compliant query to clarify a missing POA status or a false positive safety indicator, you've got to follow strict compliance steps. Review the clinical indicators, formulate a completely non-leading query, and present all clinically reasonable options. And most importantly, to avoid upcoding audits, you must always include a clear option that says no change to current documentation. Also, operationally, you should be utilizing official ICD-10 exclusion criteria to intentionally weed out false positive PSIs and setting up interdisciplinary committees between quality managers, CDI specialists, and health information management to review these charts jointly.
All right, let's tie all of this together so you know exactly what the big takeaways are from today's explainer.
To sum it all up, we are fully living in a value-based world now. Mastering those POA indicators is your absolute best tool to determine if a severe condition is going to increase your reimbursement or if it's going to result in a hospital-acquired penalty. By executing timely, non-leading CDI queries, applying official exclusion criteria, and forming interdisciplinary committees, you ensure that the hospital's data precisely reflects the true, real-world severity of illness of the patients you treat.
Now, you've totally conquered the adult quality metrics, but what happens when the patient is literally just days old? In our next lesson, we are shifting gears entirely to tackle the unique, highly complex world of pediatric and neonatal DRG grouping. It is a completely different rulebook, and for sure you won't want to miss it.
And that wraps up part 136. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshul. Keep studying those guidelines, and I will see you in the next explainer.